Um, in a post-op cardiac patient, there are several things that come into play. And vent management is not just about focusing on oxygen levels, carbon dioxide levels. You just had a patient who had their chest split open. You just had a patient whose lungs have been manipulated. The majority of patients that are undergoing cardiac surgery and having bypass surgery, so coronary artery bypass, the majority of those patients are going to have a LIMA graft, left internal mammary graft. And what that is, that's an artery that comes off the subclavian and it's adherent to the chest wall, the ribs. It's just lateral to the sternum, and the surgeon goes in there and dissects that off and uses it as an arterial graft. Okay, well, when we're in the OR, very frequently they're complaining that the lung volumes are too high. Because you can imagine you're in this small space, they're sitting down, and they've got a device that's lifting the sternum up, and they're coming in here and they're dissecting under a roof. Imagine it's like they're taking a gutter off of the roof line, but they're looking at a window like this. And you got these little balloons sitting there going like this in your face. So they're asking us to drop the tidal volumes. They're putting in sterile rags and things to push the lungs out of the way. They're moving them, they're hitting them. Lungs are really fragile, they're really sensitive. So you have lungs that get manipulated during cardiac surgery. They can have postoperative injury. They'll have atelectasis, mucus production, blood in the lungs. A lot of trauma can happen during just a routine, normal open heart surgery. And so you have to keep that in mind when you're ventilating these patients. Then you have patients who are on mechanical support. They may have a balloon pump or an Impella, or they're on, doses of inotropes or pressors. The way you ventilate those patients' heart will affect their hemodynamics, right? So lung management is very important in a fresh, fragile, open heart patient. It can make the difference between getting them extubated early. It can make the difference in the amount of pressor and inotropes they require. It can make the difference in the amount of sedation they need. It can make the difference in the amount of fluids they need. Okay, and so all these things can be impacted by how you manage those lungs. Okay. It is very important when you're managing post-op hearts that you select and have the proper vent settings, the proper sedation, so that you don't have a patient who's uncomfortable on the ventilator, who's dysynchronous with the ventilator, whose sedation levels are inadequate, whose sedation levels are too much, so that you don't fall into these pitfalls where you have low oxygenation, you have increasing fluid requirements. Then you can, these patients are at risk for post-op pulmonary edema, reperfusion injury after cardiopulmonary bypass. Just the manipulation of the lungs can cause leak of fluid into the intercellular space and cause reperfusion injury and pulmonary edema. So vent management is important, okay? So that's why we're here. That's the big picture. That's why we're talking about lung management, vent management, because ideally our goal is what? Leave them on the vent for a month, extubate, right? So we need to target these goals quickly, get them through the first, in my opinion, hour and a half, and start making sure they're not bleeding, they're hemodynamic stable, you got your labs back, your ABG, your chest x-ray, and then the goal should be, let's get them off the vent, okay? Because I don't see anybody in this room walking around with a ventilator and an ET tube, right? It's not normal, right? It's not physiologic. It's not something the human body wants. So we need to get that off to prevent things like, further trauma, pneumonia, ventilator associated complications, right? So that's the big picture. So key strategies, okay. when I teach my, when I had residents and now I have CRNA students and everything, when I teach them about lung physiology and hemodynamics, what is the goal and what do we, we have this pump, it's called the heart, and we have these lungs, and our goal is to perfuse organs, right? So we have to get oxygen into the lungs, into the capillary system, into the pulmonary veins, into the left heart, and then that has to be pumped, and it has to go to the vessel-rich group, the brain, the liver, kidneys, all the vital organs, right? Okay, so you have to know some things about pulmonary physiology. You need to know things about cardiac physiology, right? That's why all you guys are in the ICU, to learn physiology, to learn sedation, right? To optimize these things so that we can get these patients further along. Okay, so when you're setting up a ventilator, when I'm setting up a ventilator, I take certain things into consideration when I'm trying to figure out vent settings, okay? And what are some things that we can manipulate on a ventilator? Tidal volume. Rate. Heat.
FiO2.
FiO2. Okay. All right. So what are the goals in when we're setting the tidal volume, the rate, the FiO2, and the peak? What are our mechanical goals, not our physiological goals? Okay. Our mechanical goals are, let's prevent volutrauma, right? Let's prevent barotrauma. So what's volutrauma? What's barotrauma? Okay, volutrauma is where you're putting too much air in the lungs. Barotrauma is where you're forcing too much air in the lungs. Both things, when you make a lung, a balloon, snap open, close, and you're causing barotrauma, volutrauma, both things have been shown to induce ARDS. That's bad, right? Okay. So our first and foremost goals is we don't want to induce barotrauma and volutrauma, right? Okay. Therefore, how do you pick a tidal volume?
Like size.
Okay, what size? Their height?
Height and age.
Hmm?
Height and age, I don't know. Weight.
Weight, which weight? Actual?
Dry.
Dry weight?
Or estimated ideal.
Ideal, okay, ideal body weight, right? Because when we get larger, our lungs don't get larger, right? They stay the same size. Your mass may increase, but your lungs do not. Okay. So, is there a calculation that we can use to determine proper tidal volume? Do y'all have?
I bet there is.
There is.
What it is.
You're not supposed to know it, right? That's why you're here. But if somebody does know it, yell it out. Or yell it a guess. We're all friends here. Okay, let's think about it. If we're using ideal body weight, what's the normal tidal volume for a patient? What's your tidal volume?
Your ideal body weight is
6 to 8. So the way you can remember that is to think about, well, what am I breathing every time I take a breath? Okay? I guarantee you at rest, sleeping at night, you're not taking a 6 to 8 mil per kilo per minute breath. You're not. Okay? But that's how we ventilate our lungs. Okay? That's the standard. So just remember that. 6 to 8 mils per kilo ideal body weight is what we put on the ventilator, which is a lot. Now, we used to do 10 before we learned about barotrauma and volutrauma, but that's a lot. You're probably sitting there right now and breathing about 250 to 300 cc's, just sitting there going, what's up? Right? You take a 400 to 500 cc breath, you're doing this. Okay, so just remember that when you look at your tidal volumes on your patients, okay? So then we set, what's our next setting that we can manipulate on the ventilator? we set our tidal volume. We don't want to have barotrauma, volutrauma,
Peak.
PEEP. What is PEEP?
Pressure.
So
Sort of.
It's the
positive.
pressure- The pressure left in the lungs after expiration is peak and expiratory, or peak and expiratory pressure.
Not exactly, but you're on the right track. Positive and expiratory pressure. So it's not a peak and expir. It's the pressure in the lungs after exhalation. So it's what's keeping the balloon open. Okay? So what's the pressure in there right now? That's my peak. Okay? When you have a patient who's sedated, not breathing on their own, and has an endotracheal tube in, if you didn't disconnect them from that closed circuit ventilator, what do their lungs do? They deflate like balloons. We're constantly fighting that deflation in the OR because we're constantly taking them on and off the ventilator. We're inducing atelectasis. Atelectasis is collapse of alveolar sacs, okay? When you lay down at night, you're producing atelectasis. When you wake up in the morning and take a deep breath or cough, you're getting rid of your atelectasis, okay? Everybody has it. If you are a belly sleeper, you're gonna have atelectasis here. If you're a side sleeper, you're gonna have atelectasis here. You get what I'm saying? If you take a patient and you disconnect them from the ventilator, they're gonna have a lot of atelectasis. Now, depending on if they have COPD and they lose their elasticity, they don't deflate as well. But that's what PEEP does. PEEP treats atelectasis. Why do we care about atelectasis? What happens if you have big shit, Collins? Got some atelectasis. Well, one, it makes a chest x-ray look ugly. We don't like that. We like pretty chest x-rays. What are you gonna say?
Well, it would make it so the alveoli can't open, right? So you have peak, you want a specific peak to keep the alveoli be able to open up and not collapse with fluid.
Why do we care about whether our alveoli are open?
Oxygen. Yes.
That's where oxygen exchange occurs. That's where we exchange oxygen for CO2. We need those little air sacs. That's the whole point. Open. Okay. So PEEP, positive and expiratory pressure, helps us improve atelectasis, which helps us improve oxygenation. Okay? I'm gonna set that to the side right here for just a second because we're gonna come back to it. What's another setting that we use along with tidal volume on our ventilator? Rate. Well, how do we decide rate, and what is our goal when we're setting a rate?
Blowing off CO2.
Blowing off CO2. Our rate determines our minute ventilation. Our minute ventilation is our tidal volume times our rate. You need a certain minute ventilation to make an ABG look pretty. We like pretty ABGs. Why do we like pretty ABGs?
Balance.
Balance. We want a normal. What's the first thing on an ABG we look at? pH. If we set our tidal volume and our rate incorrectly, we will not have a normal pH. And those little enzymes that are circulating, making all of our bodies functions properly, they like normal pHs. All those drugs that we're giving the patient to make their blood pressure and their heart work, they like a normal pH. So we have to set our minute ventilation with our goal being a normal pH. Okay? What's the next setting that we can manipulate on a lung? FiO2. Pretty obviously why we care about FiO2. Okay? Depending on what state your lungs are in, we got to get that oxygen transferred over into the blood. It determines our oxygen carrying capacity. How much our hemoglobin's holding, how much is dissolved in the blood. If you got shit lungs, you're gonna need more of that oxygen, right? Is oxygen good for the body?
To
It-
an extent.
Hmm?
To an extent.
To an extent. Are we all breathing 100% oxygen right now? No. Would it be okay if we breathed 100% oxygen? Hmm?
For a little while.
For a little while. What happens after we breathe it for too long?
Build up CO2.
It's toxic to lungs. It can start to cause lung damage. It can start to cause alveolar damage. So we can put them on 100% oxygen. Do you ever extubate someone on 100% oxygen? No. Why? Because it's a crutch. It makes your ABG look pretty, okay? But it will lure you into a false sense of security, right? You need to know what that patient's gonna do when they're not on 100% oxygen. Because the goal is not to extubate them and put them on an honorary breather or a BiPAP. That's not the goal. Sometimes we do it, you know, that's the art of medicine. Sometimes we do it. But you don't want to. And it's toxic. So you want that FiO2 less than 60%, 50%. You want to get that off as fast as possible. So you want to titrate that to a SAT of above 92%, okay? Now, back to PEEP. PEEP can cause barotrauma, right? Okay. How many patients have you seen, especially with a certain surgeon? What's a normal PEEP that your patients come out on?
5 to 8.
5 to 8. Okay. Do you ever see 10? Okay. One surgeon in particular brings all his patients out on 10. Why does he do that?
Helps cardiac output. No.
No, but you're getting there. There's a reason he does that, and it's not wrong. I've done it. I do it a lot sometimes. But it's not exactly physiologic, and it's not exactly beneficial to your pulmonary physiology and your hemodynamics, but it's very beneficial for bleeding. That's why he does it. So when he has that end expiratory volume pressure of 10, it's almost like he's putting a rag on the heart and saying, please stop bleeding. Don't bleed. Don't bleed anymore. Please stop bleeding. Just don't bleed. Don't bleed. I don't like your bleeding. Just stop. 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 Okay? He's trying to tamponade the heart to prevent bleeding. Is it right? Is it wrong? It's neither. It's a good strategy. So when you see your patients coming out on a PEEP of 10, that's usually why, unless they're having an oxygenation problem. And if they're coming out on a PEEP of 10 because they have an oxygenation problem, you ain't extubating those people quickly, and you're in a world of shit. The patient's in a world of shit. It's not good. Okay? Can you bleep out things? So anyway, what are some problems with PEEP? These patients are fragile. They're on mechanical support, possibly, and they're definitely on inotropic compressor support. What are some, we talked about the beneficial effects of PEEP, right? Prevents atelectasis, helps us to oxygenate. You may see your patients go on increasing amounts of PEEP for oxygenation. Why is that? We're trying to prevent atelectasis. We're trying to open up those alveoli. That's why we do it. What are some not so beneficial effects of PEEP?
Can it affect our index? Like if you have a high PEEP and like you can wing your PEEP down if you're able to help your contractility of your heart.
Yeah, there's a couple components of that. So you're on the theme of it affects hemodynamics, right? Okay. Have you heard any of your more experienced nurses and doctors say, we don't want a patient on a PEEP of 15, 20, we gotta worry about, their hemodynamics? You kind of maybe intrinsically know that high levels of PEEP can affect the blood pressure. Do you know why? I want everybody to take a huge deep breath and try to hold as long as you can until you pass out.
Where's Hudson?
Nobody wants to do that? Nobody wants to do that?
We want Hudson to do it. Where is he?
I mean, think about it. If you take a huge deep breath and you hold that deep breath, you're going to start to kind of get a little woozy, right? You're going to start to kind of see some stars. Why is that?
Does it affect your venous return?
Affects your venous return. Imagine you got these big balloons that are tamponading the chest, and it's pressing on things. So it's going to be pressing on the liver, inferior vena cava, superior vena cava. It's going to shunt blood down into the legs, up into the head. We need that blood back into the heart, right? So it drops your preload. That's why high levels of PEEP are bad. But to your point, PEEP also helps contractility. Because on the right side of the heart, where it's preventing blood from going out or coming into the chest, on the left side, it's actually promoting blood leaving. Weird, isn't it? On one side, you're preventing blood from coming in. Well, just like you're squeezing that blood and forcing it out of the chest, you're squeezing that blood and forcing it out of the heart. So it improves your stroke volume. That's why when you have a patient who is hypovolemic, a COPDer, and you put them on too high of a tidal volume and too high of a PEEP, you'll start to see one of the most recognized symbols of hemodynamics responses to fluid. You'll start to see their pulse pressure vary. You'll start to see their heart lung do this. Systolic diastolic. You'll start to see your pulse ox do this. Because on that upslope, that PEEP is forcing the blood out, and on the downslope, you're preventing that blood from getting to the heart. So you start to see the sinusoidal wave of your heart line. That's not a good sign. It doesn't mean your patient's hypovolemic, but it means that you're not getting enough blood into the heart. Your preload's down, and something's wrong. Whether you've got packs in the chest, too high of a tidal volume, too high of a PEEP. But it does show that if you gave that patient fluid, they'd be fluid responsive. And that's another lecture about hemodynamics. But high levels of PEEP can be very dangerous. Okay? So that's why you have to keep that in mind. All right. We talked about preload, venous return. And the other thing we need to think about is our sedation, making sure that patient is synchronous. You don't want a fresh heart patient dyssynchronous with the vent, wide awake, while you're trying to get your chest x-ray and ABGs and all this other stuff and trying to figure out and getting them settled in. Because what's that doing? You're preventing them from resting. You're preventing them, they're gonna cough. They're gonna cause atelectasis. They'll cause barotrauma. They can cause a pneumothorax. They can cause shunt physiology. All things that you don't want to do in a fresh heart, okay? So maintaining their sedation, getting them on a proper vent setting, getting their physiology to where we can get an ABG that is reasonable for extubation are all the reasons why we think about tidal volume, respiratory rate, FiO2, PEEP, how it affects the hemodynamics, okay? Let's go over this real quick. So we've talked about why vent management is important. We've talked about the settings that we can manipulate and why they're important. We've talked about how our vent settings can affect our hemodynamics. Let's talk about when do we what criteria do we want to meet for extubation? So in general, how long are you guys leaving patients on the vent before you start to think about weaning them to extubate?
We turn the propofol off in an hour, and then we start working on making sure that everything's weaned down to sufficient levels and getting them awake.
So about an hour after they get
Arrival.
upstairs, arrival, okay. And then that's when you guys you'll start to wean your sedation and you do like a spontaneous breathing trial? Okay, all right. And then you do a spontaneous breathing trial for how long?
15 minutes.
15 minutes, and then you get a gas, and then you look at the gas, and depending on, you know, what kind of pressure or inotrope support they're on, and assuming you got them down to less than 50% and they have a reasonable gas. What other criteria do you guys look at for meeting extubation criteria?
Rapid shallow breathing index of less than 115. Greater than, less than 115.
Okay, so rapid shallow breathing index, what else?
Based off our order set, we don't extubate depending on chest tube output, hemodynamic instability,
Okay.
and then ABGs, whatever that shows.
Okay, so assuming no instability, chest tube output's reasonable, and ABG is good. So you look at rapid shallow breathing index. Is there anything else you guys look at?
Temperature.
And I mean, vent setting wise.
Just vent setting.
Ventilator related.
FO2 is less than 50, peaks 5 to 8. That.
Normal rate not to get Nick on the vent.
Rate less than 30.
Yeah.
And they have to pull good tidal volumes on their CPAP trial.
Okay. All right. So, what is rapid shallow breathing index?
I've literally never heard of that.
I was just gonna say, I've never heard that.
That's good. So rapid shallow breathing index. Okay. So rapid shallow breathing index is your respiratory rate divided by your tidal volume in liters.
Say that again.
Respiratory rate divided by your tidal volume in liters. Okay. So that means if they're breathing 500 cc's on their spontaneous breathing trial, it'd be whatever the rate is divided by 0.5. Because a lot of people screw that calculation up, including me, sometimes when I forget that. So it's in liters. So remember where you put your decimal point, okay? And you can think of it, what it predicts successful weaning if your rapid shallow breathing index is, usually they say less than 100. Some studies say less than 70. Is a very strong predictor that that patient will successfully extubate. Okay. So think about this. Which patient do you think is going to successfully extubate? Patient A. Or patient B. Which
You're
patient?
in your atelectasis.
Patient A or patient B?
A.
A, because they had a low respiratory rate and a high tidal volume. That's what rapid shallow breathing index calculates. If their respiratory rate is low and their tidal volume is big, makes sense, right? The scary number, this little thing they say, rapid shallow breathing index, always makes people's eyebrows furrow and they're like, Yeah, I've heard that. That's a good thing. Yeah, it's rapid shallow breathing. What was it? It was less than 100. I think we're okay. All right? But it's not a big complex thing. Just think of, do you want patient A or patient B? We want patient A. So you want their respiratory rate to be low and their tidal volumes to be big. That's all that is. And it just quantifies it. It just gives you a benchmark. So that instead of using your biased eyeball test, you're using a number that everybody can accept and agree on to say, hey, they're gonna wean successfully.
You can see it on view number 5 on the older events.
Thanks, Joe.
He's so smart.
He is so smart. Now, another one is forced vital capacity.
Yeah, that's.
So forced vital capacity, that's another one. That's something you can do, have the patient do, as long as they're not freaking out on the vent. Hey, take a deep breath and hold it, and then blow everything out. Okay. Less than 15 mils per kilogram, not good. So you want it above 15 mils per kilo, okay? And then another one is a negative inspiratory pressure, the NIF, okay? Now, those are the standards that we use for mechanical weaning success, okay? That's just mechanical weaning, meaning they have the mechanics to breathe on their own by themselves. Then you have to also take into consideration the big picture. Their physiology, how well are they oxygenating? How well are they pumping that blood? What kind of drips are they on? What's their chest tube output? Their level of sedation, things like that, okay? All right. That's about all I have time for.